Tyler here, and today we're going to be talking about lower limb amputation. So we're going to jump right into it. So what is it? It's the removal of a limb or part of a limb at or below the pelvis, and it accounts for 86% of all amputations. We have a list of indications to the left here. We have in utero. We're not going to talk about that at all. We're really going to focus on acquired today, which is due to disease or trauma. So traumatic amputation is the result of an accident, which includes war, but most commonly you're going to see car accidents or work-related accidents. And we have therapeutic and prophylactic, which we're also going to talk about. And these are reasonings on the right-hand side here. So most of them occur due to infection or peripheral vascular disease and diabetes. So we're going to move on really quick. We're going to talk about contraindications to lower limb amputation. The only reason that they wouldn't amputate a limb is due to poor health. The person can't handle the anesthesia or the surgery. But in most cases, if not all, that illness that's causing it is due to the limb. And amputation is always the last option. So if they can save the limb without having to amputate it, they will. So it's really a last-ditch effort to save somebody. So we'll talk statistics here. And so the U.S. citizens living with amputation is 1 million, which is a pretty high number. And trauma is the second leading cause. It's estimated 20%, which is pretty low, but it's the leading cause in younger patients. So a lot of younger patients that you're going to see are due to traumatic incidents. PVD and diabetes is the first leading cause by a long shot. 80% of all amputees are amputated for this reasoning. Diabetics are 8 to 25 times more likely than non-diabetics to get an amputation. 55% require second-line amputation, which is 2 to 3 years, which is pretty significant. And PVD, 60% of all PVD cases are also diabetic, so those two really go hand in hand. And it's most common in ages 55 to 75, so it's a real elderly population. So most of the people you're going to see with this with PVD are going to be elderly. And 50% of PVD amputees will die within 5 years. It's a really high mortality rate, so keep that in mind. So for prevention, for traumatic incidents, having a safe work environment and driving safe are huge. There's not really much you can do other than that. For diabetics, managing blood sugar, eating healthy, checking feet for ulcers. A lot of times what happens is they have poor circulation in the feet, and that causes sepsis, gangrene infections. So checking your feet is a pretty big deal for diabetics. And exercise. And for peripheral vascular disease, exercising, quitting smoking, managing cholesterol, keeping low blood pressure. And this table here to the right indicates kind of levels that you want to keep below to keep safe from risk of cardiovascular disease, something we've talked about pretty extensively. So we're going to talk about pathophysiology of PVD amputations really quick because it's a pretty big issue. So PVD is essentially reduced blood flow to an area. And this is due to the pre-existing condition of atherosclerosis and/or diabetes with instances of thrombi or emboli. So we'll talk about that really quick, but atherosclerosis is built up in the plaque in the arterial walls due to endothelial cell dysfunction or damage. So you have some endothelial damage, you have this buildup of plaque, and then this buildup of plaque, you have a thrombus that gets stuck in there. And then when that happens, you have uncontrollable soft tissue, or bone infection, tissue loss, and pain at rest to ischemia. And that's really what is indicative of lower limb amputation. And down here to the right, you can see a healthy artery versus an unhealthy artery. So types of amputation, unilateral versus bilateral, pretty simple here. One side is amputated versus both sides are amputated. We're going to move on really quick and talk about types of amputation. So the main thing we're trying to get here is that the prevalence of these and what it does with the functionality. So these are numbers that are excluding diabetic patients. There would be higher for partial foot if it were including diabetic patients. So 43% partial foot, pretty high functionality, isn't too hard to get around, workout, all that kind of stuff. Below the knee, it's called transtibial. You have high functionality. You still retain use of that knee joint and distal attachments of upper limb muscles. Decently high prevalence at 28%. Knee disarticulation, all disarticulations are through the joint, so you retain. It's a little bit easier, especially with the knee. The femur is still intact. You can bear weight. Above the knee is when you get a little where you start to lose functionality. You lose quad and hamstring control, and walking with prosthesis becomes more difficult, and that's 26% of all amputees. And moving down the list here, you have hip disarticulation, which you can see here, removal of the almost all the femur or up to the head, and hemipelvic, which is removal of the pelvis. The big thing we're trying to get here is the more proximal you get to the body, the more you lose functionality. So the rehab process, so you starts off with post-op, which main here is just healing and a little bit of range of motion strength. Then you have education and emotional support. It's really, this whole process is multifaceted with emotional, psychological, and physical rehab. So that it varies based on what kind of injury you have. So it goes from surgery to discharge. You have pre-prosthesis, which you have limb shaping, so shaping the nub, skin care, and still a little bit of physical rehabilitation. You have some cardiovascular training, mobility without prosthesis, and restoring your locus of control, which is how well you feel you can move with this limb. So obviously, if you lose that limb, you're going to have a change in your balance. You kind of restore your confidence in yourself that you can do ADLs. And that's about 6 to 8 weeks after discharge. Then you have the prosthesis part, which you have a pretty good sized team that makes prosthetic based on the needs of the patient. You have physical therapy for training, kind of getting back in the community. And the big thing here is integrating back in the community. So being able to do stuff you were able to do previously. It's about 10 to 11 weeks. And during this process, you have kind of initial rehab, which is just basic functioning, getting used to weight transfer, proprioception, weight bearing. And then you move on to advanced, which is starting to tackle things like stairs, getting up and off the floor, moving around crowded environments. And then this is an ongoing process. So for the first 18 months, you have a follow-up every 3 months, and then you have a physical every 6 months for the rest of your life. So you have lifelong prosthetic, functional, medical assessment, and psychological support. So this is a lifelong condition that these people are dealing with here. So medications, it's going to vary based upon the age and the cause of the amputation. So if it is due to a cardiovascular issue, you may be taking drugs due to pre-existing conditions. So check with them in on that, right? Due to trauma, most likely not on medications. You have to be aware that veterans might be on medication for some psychological conditions or something like that. So check in with them, make sure you know what they're on. The only medication that you really need to worry about with all lower limb amputee patients is to treat something called residual limb pain, which is that residual limb, they'll have pain in that stub, and it's treated with a combination of methods, but they might use antidepressants and anticonvulsants, which might kind of contraindicate for them for exercise testing, might change your workout plan. Now we get to move on to how lower limb amputation affects quality of life and exercise. So energy and costs increase with amputation, and it lowers that person's exercise capacity. So if we look down to this graph this picture right here, for people that have trans-tibial amputations or anything below the knee, their energy cost increase is going to be from 0 to 15%. As you move above the knee to a transfemoral amputation, the energy cost is going to jump from 30 to 60%, okay? Which is a pretty huge increase. And for bilateral, both, that's 280%, which is a pretty big deal. So this really makes a big change in terms of what they're able to do aerobically and even weightlifting wise. So this is why it's kind of important to exercise, to do a greater exercise test with these people. You have increased risk for friction and skin infections. We're not going to talk about that too much. Increased demands for trunk stabilization. So we're going to throw some core exercises in there. They have decreased balance capabilities. So a study found that they compared lower limb amputees that were fit and lower limb amputees that were unfit, and then just regular population people. And even the fit amputees had a hard time stabilizing. So they had poorer static and dynamic balance, And so basically what this means is that you do have to focus on some balance capabilities. You do have to be aware if you're lifting with them that they might not be able to do some stuff other people can do. You have to be supportive there. And this is really due to the ankle's role in stability. And finally, a pretty big deal here is that there's an increased risk for diabetes, for obesity, and metabolic disorders, and that increases as the amputation gets more proximal, as you can see here with these statistics. That increases pretty rapidly, and going almost to 50% when you get to transfemoral. So, person that you're getting here, they might be obese. Be aware of that. And the big takeaway here is that the more proximal you get, the bigger the detriment is to that person's physical activity and their lifestyle. Okay. So the benefits of exercise. So you can decrease strength asymmetry. So if that person has an amputation in their right leg, their left leg might be stronger. So you can kind of work that out, and that's illustrated in this picture here. You have a strong arm and a weak arm. So exercising can kind of work those out. Some studies have pointed to a possible decrease in metabolic demand, so increasing that person's exercise capacity. Studies still need to be done on this. There's improved balance capabilities, even though I just mentioned that athletic fit lower limb amputees still had issues with balance, you can still see improvements. And there's going to be a huge decreased risk for obesity and metabolic disorders, which is big, as you see in the previous slide, where 50% of transfemoral were obese. So it's a pretty big deal. So moving on to our case study. So Michael's 35 and receives a transtibial amputation after a car accident. It's been about a year and a half since he has been with his prosthesis. Before, he was active and lifting weights and running regularly, and since he's been mostly sedentary. His goals are expressed on the following slide. So really not too many risks here. He's pretty healthy. He's a little bit on the high end in terms of his BMI, but his risk classifications because he has two risk factors, and he's asymptomatic. He's at moderate risk. So Michael's goals here, so he has improved balance, lose weight, and lift weights again. And we're going to get into our exercise testing. So we're going to run the whole gambit here. We're going to do cardiovascular exercise testing. Studies point that upper and lower arm megantry is best for amputees. We're going to do some muscular strength testing just so we can get a good idea of what we can assess. Muscular endurance, flexibility, and we're going to do balance. Timed up and go test is a great dynamic and functional stability exercise. It's going to show us how we can move with that prosthesis. Unipedal is a nice static assessment. So the warm-up's pretty simple here, 8 minutes, 4 stretches each way. Aerobic conditioning, so we're going to do 4 to 7 days per week. We're going to start at the lower end since he's been a little bit sedentary. So we're going to basically start about 40 to 50% of heart rate reserve, but we can move up to 80, and another 11 to 16 on Borg scale as well. And the time, 30 to 60 minutes. We're going to start again at that lower end of 30 minutes and move up a couple minutes each week, depending on his response. And the type, stationary cycling, running, swimming, pretty much anything. For resistance training, 2 to 3 days a week. We're going to start off with 2, 60 to 80% of 1 rep max, or weight allowing 8 reps. Reps, we're going to do 8 to 12 for 2 to 3 sets. And we're going to have about 2 lower, 2 upper, 2 core. And here, you can really do a good amount of lifts. Since he was lifting before, we do have some pretty complex ones, such as a stiff leg deadlift and stuff. We can start off with lower weight and just see how he adjusts and move on from that. We have a lot of exercises for core. We have bird dogs. We have lying clamshells for hip mobility. We have upper body exercises, so we do have a pretty big amount of exercises. Flexibility, 5 to 7 days, stretching to mild discomfort, holding it for 10 to 30 seconds for 2 reps. We're going to do dynamic and static. So here's the list of stretches we have prescribed here. Good amount of lower body and upper body. We only really have one upper body, but lower body is most important here. And then balance and coordination, 2 to 3 days a week. Reps, it really depends. So we're kind of start off with maybe, like 4 and move up. And we just have some stuff kind of getting his locus of control, getting his balance under him, getting used to some ballistic movements as well. Just kind of letting him trust his prosthesis. And here's where we're excited. And we're good.